There are tons of shoulder conditions, and we will break this down as simple as we possibly can. And towards the end, I'll show you the DBQ for shoulder conditions and what is needed for service connection. The overwhelming majority of shoulder conditions will be rated based off of range of motion. So your shoulders coming up, coming down, and round and round. So you see the scale going from 0 to 180 degrees, and based on the angle of your range of motion, this is exactly how the VA is going to rate your shoulder. With the shoulder, there is a dominant and non-dominant rating. So I am right-handed. So if my right shoulder couldn't go past 40 degrees, I would be rated at 30%. That same scenario, but if it was my left, then I would be rated at 20%. The overwhelming majority of shoulder disabilities I see are 10 and 20%. Looking at the 40% criteria, it's less than 25 degrees, and as you can see, you have a very, very limited range of motion. For the loss of use and shoulder replacements, very, very similar to range of motion, and for replacements, the VA could award a temporary 100% rating and then rate residuals post-surgery. Looking at dislocations, which is when your shoulder pops out of place, the same dominant and non-dominant factor applies, and you can receive a 20 or 30% depending on how often your shoulder does pop out of place and your movement with your shoulder and arm. This also includes the collarbone. Now, bones are where the money is at for shoulders, and I've seen this in veterans that had a very, very serious accident and they broke their shoulder, and now there's some type of residual from that injury. Looking at humerus, which is above the elbow and also known as the funniest bone in the body, this can be rated anywhere from 20 to 80%, and the same dominant and non-dominant factor applies. You can see how the bone has broken, and it goes into the healing of the bone, if at all, causing a visual deformity. And at higher ratings, starting at 50 and 40%, you see the arm is damaged and never really heals. Now pain in your shoulder will push you to 20%, and the VA will take the highest of the ratings when it comes to range of motion and pain in your shoulder. Shoulder pain with a bilateral factor and 20% in each shoulder is absolutely solid, and if this applies to you, you might want to start forming your evidence-based claim. Now, the DBQ for shoulders is pretty long-winded, so I'm going to summarize, and the important piece of this is whatever portion of the DBQ applies to you, you really want to focus in on that little portion and understand how that CMP exam is going to go down. More so, as veterans, we really don't understand our symptoms, and we certainly have trouble articulating our symptoms to the VA, our healthcare team, and of course, CMP examiners. And that is absolutely crucial for our claim. So looking at the DBQs can really just put you in the right frame of mind to understand what the heck is going on with whatever disability you're wanting to claim. Now, jumping right into the DBQs here. And so this is the DBQ for shoulder and arm conditions, disability benefits questionnaire. That's DBQ. So we have all this stuff here. Was the veteran's VA claims file reviewed? Just of note, if you're getting one of these privately and that answer is no, all of a sudden this DBQ means diddly squat, okay? So keep that in mind, of course, and it breaks down. If you say no, what did you check, okay? Now, looking at section 1, diagnosis, there are tons of diagnoses here. ICD is a international coded disease. International Classification of Diseases, It's just kind of a well-known code, and in VA healthcare, in your Blue Button reports, you could see ICD codes or SCT codes. So definitely word search those if you haven't already. But tons of conditions, and then there's a section below here that talks about other conditions related to the shoulder. Medical history, right? We definitely want to submit evidence for sure. And looking at initial range of motion, keyword there is initial because it's going to happen multiple times. And so right shoulder, left shoulder, and you can see the flexion, abduction, rotation, and external and internal rotations for that. Same thing with the left shoulder here. Any abnormal range of motions, excuse me. And then section range of motion after repetitive use testing. Again, right and left shoulder. There you go. Same thing here. Now, looking at pain in right or left shoulder, this is absolutely crucial. And so if you have pain in your shoulders, you definitely want to speak with your examiner about that. And then functional loss and additional limited range of motion. So the loss of use, right? Look at pain on movement, swelling, deformities, disuse, instability, all these, just understanding what this stuff means and what you have and what you don't have will absolutely help your CMP examiner understand what you have and what you don't have. As always, we want to back this up with medical evidence anyways. More stuff on the shoulders, muscle strength testing, absolutely, for the loss of use, or like surgeries, right? Residuals from a surgery or an injury. All of this comes into play. Muscle strength, ankylosis, that's just another way to say the loss of use. Rotator cuff conditions, especially if you've had surgery, that's going to come into play here. And scrolling down, we see instability, and then the bones, right? All of that stuff, joint conditions, conditions or impairments of the humerus, the funniest part of the body, right? You can laugh in the comments. That would definitely help me out. And then surgical procedures. And just because you claim shoulder conditions, for instance, if you haven't had surgery or you don't need surgery, this piece is not going to apply to you, right? So whatever does apply to you, you really want to hone in on. If this does apply to you, then you want to really focus on this section as well as all the other applicable sections. Then other pertinent physical findings, complications, scars, symptoms, and scars. So yes, you can be rated for scars on this one. And let's talk about common secondaries to shoulders, right? Nerve damage. So just like the lumbar spine has radiculopathy and sciatica nerve damage in your legs, the same thing applies for your arms. So you can have nerve damage in your arms coming from your neck or your shoulder conditions, especially if there's a surgery in there. Then you have nerves in your hands, okay? And so the carpal tunnel would be these two. And then cubital nerve would be these three. And the middle one, I'm not sure which one that falls into. I'm pretty sure it's cubital. But you can also, those run up your arm as well. That could be a common secondary. If you have a left shoulder condition and you're overcompensating for your right, your right shoulder could be a common secondary. And so those are the most common secondaries, which are the other shoulder, the bilateral factor there, nerve damage in your arms, and then, of course, scarring from surgery or whatever that looks like for you. Now, looking at service connection, and this is absolutely critical because we want to submit evidence-based claims. And during our CMP exam, which is more important, we want to reference that evidence during our CMP exam. So it's known as the big three of what's needed for every single claim. It's the in-service event, it's a current diagnosis, and it's the nexus. I'm not saying this, 38 CFR is saying this, and you'll see those 38 CFR codes in every single decision letter that you have. So what's the in-service event? All it means is something happened in service to lead to that condition, or it manifested during your time in service. And so maybe you were in a car accident, that would be an event, or maybe you woke up one day and you had shoulder pain, right? And it's probably from doing PT, from your deployment, from shooting, from doing a lot of rucks with weapons on your back, whatever that looks like. Then you just have a medical complaint. That would be the in-service event, right? So there's evidence in service relating to your currently claimed disability. That's the in-service event. Looking at the current diagnosis, and it should say current diagnosis / documented symptoms. So current meaning within 1 year, and documented symptoms. So if you don't have a diagnosis, we know it's very hard to get a diagnosis from VA healthcare for whatever reason. A treatment plan would be documented symptoms that would lead a CMP examiner to diagnose for VA rating purposes. So if you're on pain meds for your shoulder, if you're in physical therapy for your shoulder, but don't have an actual diagnosis, That's okay. That would suffice, so to speak. Now, we always recommend getting a diagnosis for any claim whatsoever, unless you're doing a BDD claim and you're active duty. Now, the Nexus, which is the most convoluted and is really out of our control, is linking your current diagnosis and your in-service events to your military service. And so we have at least as likely as not, or more likely than not. That's what you want. There's technically a due to, which is 100%. And then on the bad end of the stick, you have less likely as not, and then not due to, which is bad, right? So that would be the CMP examiner saying this condition is not related to service. If you have at least as likely or more than likely, that's the CMP examiner saying this condition is related to service. Now, what's crucial about this is during that exam, what you need to be doing is when you are asked a question, you reference your medical evidence from service, you reference your current medical evidence, and you kind of build that continuity train saying, I was seen for shoulders on this day. Or I did rucks, I started having shoulder pain around August of 2013, whatever that looks like for you. And then you talk about your current evidence. Well, since then, I've had shoulder pain ever since. I kind of just dealt with it. And then I went to my primary care health team at the VA or private, whatever you prefer. And I'm on physical therapy, XYZ, whatever your symptoms are. By doing that, you're linking your evidence to that condition and your in-service event. And you're kind of building that continuity train for the examiner to give you a positive nexus. And that is how veterans get service connected for any claims, in this case, your shoulders.